Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article SWOG S9005 double-blind phase 3 randomized trial of the anti-progestin agent mifepristone in the treatment of unresectable meningioma by Yongli Ji et al. My name is Elizabeth Marr, and I am an Associate Professor of Internal Medicine and Neurology and Neurotherapeutics at the University of Texas Southwestern Medical Center in Dallas, Texas, United States. My oncology specialty is neuro-oncology. Meningiomas are the most common brain tumor in the central nervous system, accounting for 30% of all tumors and arising from cells in the leptomeninges. The World Health Organization recognizes 3 grades of meningiomas. Grade 1, or benign meningioma, accounts for approximately 80% of the tumors. Grade 2, or atypical meningiomas, account for 20 to 30%, and grade 3, the anaplastic or malignant meningiomas, account for 1 to 2% of cases. The incidence of meningioma increases with advancing age, and there is a female predilection with a 2-to-1 ratio of females to males. In the majority of cases, surgery and/or radiation therapy is curative. However, malignant meningiomas and recurrent or refractory meningiomas can be aggressive and are resistant to radiation therapy. To date, no systemic therapies have been developed for this disease. For several decades, the possible influence of hormonal factors on meningioma growth has been the focus of medical therapy. Anecdotal cases of tumors that were diagnosed during pregnancy or existing tumors that grew during pregnancy fueled this idea. Examination of hormone receptor expression in meningiomas identified high expression of the progesterone receptor in 70 to 80% of cases and low to no expression of the estrogen receptor. Functionality of the progesterone receptor was established using in vitro assays of cultured meningioma cells, but its role in mediating growth and invasion in vivo has not been established to date. Based on these data, treatment with progesterone receptor inhibition has been a potential therapeutic option over the past 15 years, and several small early-phase studies using the progesterone receptor antagonist mifepristone have reported some benefit. It is in this context that the clinical trial performed by the Southwest Oncology Group, SWOG S9005, is an important study in this disease. It was a randomized, double-blind, placebo-controlled trial that allowed for crossover at the time of progression for patients on placebo. Adult patients were eligible for the study if they had unresectable meningiomas, either at initial diagnosis or at the time of disease recurrence or progression. Of 193 patients enrolled, 164 were randomized and treated. 80 patients were assigned to the mifepristone group and 84 patients to the placebo group. Approximately 80% of patients in both arms were treated at the time of recurrent or progressive disease, although the distribution of tumor grade was not specified for each group. Pre-treatment tissue was available in approximately 50% of cases, and progesterone receptor overexpression was documented in approximately 90% in each group. No on-treatment or post-treatment tissue was obtained for biological analysis. The planned treatment was oral daily administration of mifepristone, 200 milligrams, for 2 years. Approximately 30% of patients in each arm completed the full treatment course, with the majority of patients coming off study prior to study end because of tumor progression. The primary endpoint, median failure-free survival, was similar in the two groups, 10 months in the mifepristone group and 11 months in the placebo group. The secondary endpoint, median overall survival, was also similar in the two groups. Patients were stratified for gender and menopausal status, prior radiation therapy, and disease status of progression versus newly diagnosed. There was no statistical difference between the two groups in the subgroup analysis. Overall, the drug was well tolerated, although an increase in grade 3 and 4 adverse events was reported, as well as an increase in endocrine-specific related side effects was noted in the mifepristone group. In summary, this was a well-done study that answers an important question regarding the effectiveness of the progesterone receptor-specific inhibitor mifepristone in the clinical management of unresectable, recurrent, or progressive meningioma. The data is clear that there is no benefit from this therapy. The study also highlights several important issues in brain tumor management, which is challenged by having few validated targets and the need to achieve high concentrations of a therapeutic agent in the cerebrospinal fluid and brain. Slow-growing tumors, such as meningiomas and low-grade gliomas, require long treatment times in order to assess benefit. Preclinical brain tumor models generally are high-grade tumors, with short doubling times that do not recapitulate the biology of these slow-growing tumors. However, despite these difficulties, recent publications of comprehensive molecular analyses of meningioma and low-grade glioma have identified new genes and pathways that are very attractive for therapeutic targeting. The important question that emerges from the SWOG meningioma study is how to study new drugs in an efficient and effective way. There will be information from animal models that can provide some indication that the drug under investigation can penetrate the spinal fluid and brain, achieving concentrations that are therapeutic, and also identify biomarkers of pathway inhibition and a cytostatic or cytotoxic response. Ultimately, however, in these slow-growing tumors, studies will need to be performed with a phase that includes short-term neoadjuvant treatment followed by surgery with evaluation of drug levels, tumor targets, and histological analysis. It is imperative that it is determined early in the workup of a new target that the drug hit the target and downstream pathway, and that there is a measure of potential response that indicates that the target is a driver mutation. Perhaps this can be accomplished by innovative imaging techniques rather than surgery. The early biological evaluation will need to be matched with a clear mandate for continuing or stopping the study based on the in vivo patient data. Otherwise, the empirical, quote, hit-and-run approach in slow-growing brain tumors, such as meningiomas, will continue to be a serious impediment to finding effective therapies quickly. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.